Assalamu alaikum to all of my students. This is Dr. Risha, working as an associate professor in Gynae Ops department, PUMS. I have decided to start the series of lectures on the Gynae Ops important topics on the request of my students. I hope this series may help you in your examinations, and this is purely for the undergraduate students, though the postgraduate can take benefit from it, but little bit this series will be in superficial way, not in a very deep as needed by the postgraduate trainees. So better is to not waste our time, and let's start. So today's topic is the gestational trophoblastic disease. In today's session, what are the objectives? Today, we'll discuss the definition of gestational trophoblastic disease, risk factor, genetics, classification, how it presents, what are the complications of it, how to diagnose, how to manage. If managed, what kind of chemotherapy should be given, when to given, how to given, what are the side effects, and in which conditions necessitates the hysterectomy. So what is the gestational trophoblastic disease? This is a kind of condition which includes a spectrum of a disease, a spectrum of a condition arising from the cells of conception ranging from benign, that is partial or complete mole, to malignant counterpart, that is invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid cell tumor. So it is classified into two, benign and the malignant one. Benign include the partial and complete mole, invasive mole, choriocarcinoma, placental site trophoblastic tumor, epithelioid cell tumor constitute the malignant portion. Okay. Now the genetics. But before proceeding to genetics, I must inform you regarding the risk factor of the complete and the partial mole or the molar pregnancy. These are not there is a list of risk factor, but only three reliable risk factors are there. One is the age. Extreme of age is very common. Molar pregnancy is common at the extreme of age, under 20 years of age or more than 40 years of age. Second risk factor, the Asian population. We all are at the risk of having molar pregnancy. Third risk factor is the prior history of the molar pregnancy. If there is a single history, once patient is having the molar pregnancy, she is at the risk that in within 2% of the cases she may have a recurrence of the molar pregnancy. But if she is having a history of twice molar pregnancy, there is a chance of 1 in 6 pregnancy to be affected in a future. But if thrice history of molar pregnancy, there is a chance of 50% the fourth pregnancy will be affected as a molar, 1 in 2 chance. So now the genetics. This is the first part of this gestational trophoblastic diseases lecture. A few points and remaining points will be covered in the next part. In this part, we'll cover the genetics, clinical presentation, and how to diagnose. While started from management will be in the next part. As far as genetics is considered, the complete mole is a diploid in nature. The patient affected with molar pregnancy, and if she is having diploid complete mole, the genetic material will be most probably 46 chromosomes, and all arises from the paternal side. In most of the cases, 80 to 90% of cases, the androgenic is the genetic material, complete androgenic. There is a no maternal component. There is a no maternal component. What happens when a sperm fertilizes a egg which is empty and has expelled out its genetic material to outside, and now it is empty, but this haploid number of the chromosome is fertilizing the empty egg. In the result, what happens, that haploid number of the chromosomes develop itself to become diploid in number and to survive. So that whole of this genetic material is from the paternal side. So it is diploid and androgenic. Mostly it is monospermic, that is one sperm is fertilizing the one empty egg and develop its chromosomes number as I have shown here. But sometimes what happen, two sperms fertilize an empty egg, right? So what they do, the two sperm fertilize empty egg which already have expelled out its genetic material to outside, and then the net result is 46 chromosomes, that is the dispermic and the androgenic one. But very rarely what happens, the complete mole can be arises from the biparental origin, means to say the both the parents having the genetic material shared in the conceptus. But it is seen in those conditions where there is a syndrome caused as complete heretiform mole, familial complete heretiform mole. This is a condition in which there is a defect running in families in autosomal recessive manner. When in a single family, two or more than two family members are affected with the molar pregnancy twice or more than twice. This is termed as familial complete heretiform mole.